I really appreciate the opportunity to talk to everybody, and there's 3 seats up here. I promise I won't ask any questions to anybody in the front row. So what I'm going to do, I'm hoping to talk for about 20 minutes and then leave some time for questions. I have a tendency to ramble on and talk too long, so occasionally I'm going to check my iPhone to make sure I'm not running overtime. So don't worry, I'm not texting or checking Facebook or anything. I'm just making sure I'm on schedule. So just for the sake of disclosures, I have no conflicts to report. I'm not a paid spokesman for anybody. I am funded by Medicare and Medicaid, but otherwise I'm purely independent. I've been at Dartmouth for 11 years now, and this is my 11th year. And what I do is hip and knee replacement, and I also treat hip and knee osteoarthritis. The way things have gone lately, I now do slightly more hips than knees because we do anterior hip replacement, and that's sort of catching on. And so I still do a lot of knees, but not nearly as many as I once did. And my goal for you for the next 20 minutes here is to go over some of the common things I hear people asking me about knee arthritis, treatment of knee arthritis, and knee replacement. Because I sort of hear the same information and sometimes misinformation that people pick up. And there's so many sources of knowledge and information out there these days that it's hard to know if what you're reading is really true or if it's driven by the desire to sell you something. Knee and hip replacement, as you may have noticed, is in the news a lot lately, and it's primarily because of the economic impact of joint replacement. While joint replacement is great for treating late arthritis of the hip and knee once non-operative modalities have failed, it's also a very expensive operation, and nationally the rates of joint replacement are going up. I can't count how many talks I go to where people show this slide and how the rates just keep on going up higher and higher. And part of the reason for that is the population's living longer. Part of it is that as people live longer, sometimes they're not happy to just sit around and lead semi-active lives. They want to get back to the things they liked to do before. And part of it may be that surgeons are overly enthusiastic in offering this to too many people, and I think there's probably some truth in that also. Last year in the United States, 600,000 knee replacements, first-time knee replacements got done. Those aren't redos, those are first-time knee replacements. And we've started stretching the age now, unfortunately, fortunately, depending on how you look at it. So the younger and younger people are getting this operation, and older people are getting the operation as well. It's not just the United States that's like that. The bottom graph is from Australia, and although the numbers are a couple of orders of magnitude lower, you can see the same thing is happening there. More and more people are having this operation. And so this is what I'm going to do. I'm going to cover 5 sort of topics that I get hit with a lot in my clinic, and to try to tell you where I think there's some truth and where you need to be a little bit careful. So number 1, I have knee pain. My doctor told me my x-ray shows arthritis. I need a knee replacement, right? And the answer, of course, is no, not always. Just because your knee x-ray shows arthritis doesn't mean you need to come and see me necessarily. Quickly review. This is a knee, okay? And we all have 2 of them, hopefully, and this is what it looks like, minus the skin and the muscles around the knee. You've got a kneecap in the front. It's got some cartilage on the back that lets it slide up against the femur. You've got a couple of ligaments inside the knee, the ACL, which, that's the bane of all football and hockey and soccer players. You've got 2 ligaments on the side here, and this whole thing is lined with cartilage, so it moves and glides, and people tend to think of the knee as a hinge, but it's not really a hinge. Well, it is a hinge, but it's also a joint that rotates, and so it's a rotating hinge in a way, I suppose. Wow, how did that happen? That by itself. When you take x-rays of knees, and orthopedic surgeons love x-rays, my friend John Hood in the back will attest to that. First thing you do when you walk in is we'll x-ray you. But there's a good reason for that. It's because x-rays are relatively inexpensive, relatively safe, and they tell us an awful lot of information about what's going on in your joint. So this particular person has a left knee over here that's mildly arthritic, and the knee on this side, it really looks pretty terrible from an arthritis point of view. And these are the 4 key sort of features of an osteoarthritic knee. The joint space narrows. And what is a joint space? A joint space is the space between the top and the bottom bone. And although you can't see it on the x-ray, what fills that space is cartilage. Cartilage that you see on the end of the chicken drumstick. It's white, it's shiny, it's smooth. And in arthritis, that cartilage gradually deteriorates and starts breaking off. You start to get little divots in the cartilage. It's no longer smooth anymore. And what happens eventually is you end up with what's called a bone-on-bone knee. So that's what bone-on-bone means. It means that all the cartilage is worn away, and right now you're rubbing bone-on-bone. And for a whole number of reasons that hurts. Nobody's quite sure why that hurts. Some people theorize that you can get heat from that exchange of bone rubbing on bone. Second thing that happens is the alignment of the knee changes. You've seen people walking around who walk around like this, and that's the most common posture for knee arthritis, bow-leggedness. A minority of people get knock knees, but most people, 85%, get bow-legged. As a result, the ligaments around the knee stretch. Sometimes the ligaments break altogether, tear. And then you start forming bone spurs, and some of these bone spurs are so big that you can actually feel them on people's legs. You feel the inside of your leg, and there's a big shelf of bone that wasn't there before, and that's part of arthritis, and it's because the body can't repair cartilage, but the body can build extra bone, probably through some mechanism that goes back to the cavemen. The thinking, or the design rationale, if I can call it that, was that if you've got an arthritic joint and you build up enough bone around it, you may actually fuse the joint, stop it from moving altogether, which makes it more stable and the pain goes away. Most people today don't let their arthritis get that bad. This is what a knee looks like through a scope, okay? And so there are times when you probably know people who had a scope of their knee where we put a camera in and we take a look at the cartilage, and if there's loose pieces of stuff floating around, we wash it out. The knee that is on your right is a pristine looking, nice knee that has perfectly good cartilage from the femoral bone, the thigh bone on the top, stop that, tibia down on the bottom, and a nice meniscus here. The meniscus is another piece of cartilage. It's rubbery and it kind of acts like a shock absorber. And you've got two of them in each knee, one on the inner or medial side, one on the lateral side. And you can see here, as the cartilage gets kind of furry and chunks start falling off, that all of a sudden that beautifully designed knee doesn't look so much like a good knee anymore. And so these are the things we try first. Remember I said you don't necessarily need a knee replacement. These are some of the things we try. Weight loss is very important. Anti-inflammatories, exercises, physical therapy to try to improve the strength of the muscles and the range of motion. Braces, injections of cortisone, injections of other things that we can talk about later. And these things have been very well studied, and there are very well designed recommendations out there that you can look up from the American Academy of Orthopaedic Surgeons, the RAND Corporation, just to name two, that talk about treatment guidelines for arthritis. And they don't go right to knee replacement. They go through a series of steps that you try, and quite often those things can be successful. Arthritis progresses from early to severe, the way that this little model shows. And I won't belabor this too much, except to say that most people, by the time they leave are in their 30s, they've got these little dings and divots and scrapes. You know, that's what college football, high school hockey, and all that kind of stuff does to your knee. But those things aren't necessarily symptomatic. Most people have that in their knee, but they don't even know it. And then this thing's got to, and so in this early stage of arthritis, weight loss, anti-inflammatories, and exercise are tremendously helpful. As you get a little further on, you start to get more degeneration. You get a bigger thickness of cartilage that gets lost. And here, again, anti-inflammatory, sometimes prescription can be useful. Activity modification. I mean, you may not be able to go up and down the stairs with an armload of wood anymore. You may have to get your husband to do it or your wife to do it for you. Injections, arthroscopy, these things are useful at this stage. And this is sort of getting into severe arthritis, large patches of exposed bone, and unfortunately anti-inflammatories and all the non-operative things I talked about are not tremendously useful at this point. Only about 40% of people with a knee like this will get relief from injections, anti-inflammatories, therapy, and so forth. Not to say it's not worth trying. 40% still means 4 people out of 10, so it's worth trying. But you have to have realistic expectations. And what we do at Dartmouth across the street is we came up a few years ago with this arthritis ladder, just trying to emphasize to people, you start at the bottom of the ladder, you don't start at the top of the ladder. And at the bottom of the ladder, there's things like weight loss and Tylenol and knee braces and exercise. And I encourage people to go through this and check the things off as they try them. And if that doesn't work, then you can sort of go up a little bit, and then you get to things like knee arthroscopy and cortisone injections and Synvisc and Hyalgan and all those other things that you can inject into the knee. And at the top of the ladder, once this has been exhausted, and look, I mean, some of these things, not everybody can take an anti-inflammatory, and I don't want to stand here and make it seem like it's risk-free. There are risks to these non-operative modalities as well. But nevertheless, the risks are usually quite small, and those things are worth trying. But at the very top is total knee replacement. And this is what a knee replacement looks like. I hope nobody gets queasy here, but this is an x-ray of a knee, looking at it from the side. You keep your own kneecap at a knee replacement. There it is there. There's actually 4 different pieces to a knee replacement, and Bill, if I could get you to grab I forgot my suitcase out in the waiting room. I'm gonna hand out some knee replacements here so you can play with them. It'll make the lecture go by faster. So there's actually 4 pieces in the knee replacement. There's a metal cobalt chrome piece on the top, a metal piece on the bottom, piece of plastic in the middle, and I hesitate to say that that's the cartilage replacement. What it is, thank you, Bill, is the polyethylene, and the polyethylene plastic in there is what acts, it's about as good as we've been able to get cartilage at this point. And this operation takes about an hour to do, but it is really only for those people who've exhausted all the other modalities that we talked about. So the second question I hear is, okay, well, I've heard all this stuff about minimally invasive surgery. This has got to be better, right? I mean, it sounds minimally invasive. And unfortunately, I think that's not true. Now, you can't be faulted for believing that, because if you go through the internet, and even if you're a researcher and you start looking at articles, and there's a dozen of them written, unfortunately, they're all very poorly designed. So you have some orthopedic surgeon who looked at 30 patients where he did minimally invasive knee replacement, or she, and another group of patients that they selected where they did normal knee replacement. And most of the older studies were very small groups, real bias in how they pick patients. So if you were big and had a stiff knee and you weren't very active, you got a normal knee replacement. If you were 45 and skinny and had been running marathons until 3 years ago, you got the minimally invasive one. So guess who got better? The people who were more fit and younger. And that was the problem with a lot of the old studies. And at Dartmouth, we finished up a study, and this is going to be published coming up later next month, called the micro study. And we actually did a study where we took 2 groups of people, and we didn't tell them whether they had the minimally invasive one or the normal one. And we didn't tell the people, the therapists examining them, if they got the minimally invasive one or the normal one. And what we found is there's absolutely no difference between the two. And it seems counterintuitive. I've got to say, going into that study, and I was the lead investigator on that, I thought for sure that the minimally invasive group would come out ahead. And we looked at a whole bunch of things. I'm going to quickly run through this. This is stuff I usually torture my residents with, but I'm going to torture you for a few minutes. What is exactly minimally invasive knee replacement? Well, this is sort of how John Insall at the Hospital for Special Surgery in the 1970s in New York described knee replacement. After you go and open the skin in the front of the knee, you cut along the inner border of the patella and up the quad tendon. And that allows you to sort of open everything up like a banana peel, get in there, do the knee, and get out. Now, as people started evolving this operation, people would still cut up to here, but it seemed kind of wrong to cut through the muscle and the tendon, and so they didn't. What they did is they pulled that muscle and tendon over to the side and cut underneath it. And in that way, they avoided cutting the quad muscle, the vastus medialis muscle. Mm-hmm. Seems like it should make the operation better, hurt less, maybe faster recovery. Don't dwell on these graphs too much, but these are the 2 groups in terms of their ambulation. And what we did is we had a research assistant call these people once a week for 8 weeks, and those patients, 65 in each group, kept a diary of what they were able to do that day, whether they needed a cane, a crutch, a walker. Outdoor ambulation, indoor ambulation, outdoor ambulation showed absolutely no differences in those groups for that 8-week period. In other words, the people who had the minimally invasive surgery couldn't get rid of their canes and walkers and crutches earlier. Everybody did well, but they did equally well. This is something called the UCLA activity score, and this is a 1 to 10 scale. Number 10, I think, has kickboxing, hockey, the real physical stuff. 0 and 1 is taking your dog for a walk, I think, something like that. But it's a whole scale, and patients answer this scale, and they simply check off which activity they were able to do that week. And again, absolutely no difference between those groups. Activities of daily living. Here we included things like vacuuming, cleaning, going up and down the stairs, driving a car. Again, absolutely no difference in between the 2 groups. We looked at pain medication, because the other claim that's been made is that minimally invasive knee replacement hurts less. And so we thought, what better way to measure this? And we measured it in a couple of ways. We actually asked patients to rate their pain from 0 to 10, but we also measured the amount of morphine that they used after the operation. And this is just in the hospital. So this is post-operative day 0, day 1, day 2, day 3. And you can see right in the beginning, the use of morphine is very high. First day or 2, this thing hurts. I mean, you need some morphine to get through that. And by the time you get to the 2nd and 3rd day, morphine consumption goes down significantly, but it goes down equally in both groups. Again, beating a dead horse here, but there's no difference. And in fact, that extends out over 8 weeks. Even over the first 8 weeks after knee replacement, minimally invasive techniques don't seem to make a difference. Again, as I said, I was surprised by that result, but this study is probably the best designed one out there right now. And I hope it's going to lead to people pulling back on this misleading advertising that makes people think that anything about a knee replacement could possibly be minimally invasive, because it's not, let's face it. So number 3, after knee replacement, I won't be able to do all the sports and activities I want, right? Funny thing is, usually the patient's asking me this, the guy that walks in with 2 canes and he's worried he's not going to be able to jog anymore. And when I ask him, when's the last time you were able to jog? Oh, 25 years ago. So I have to concede, no, I'm not going to let you jog. But I'm going to let you do a lot more than you're doing now. And this is an individual thing. There are no strict guidelines as to what you can and can't do with a knee replacement. And there's going to be a difference. What I tell you is going to be different than what John Hood tells you, maybe. Maybe not, I don't know. But most surgeons will allow things like hiking, skiing, snowshoeing, skating. I let my patients play hockey. I've got a couple of them that play hockey, golfing, and bicycling. I tell them all it's going to be different than when you did this with your 20 or 30-year-old knee. It's going to feel different. It's a knee replacement in there. It's not the thing you were born with. And I have to temper people's expectations. You may not be able to get back to singles tennis. Maybe you'll have to settle for doubles tennis. And maybe you won't be able to walk 18 holes of golf. Maybe you'll have to take a cart or just do 9. Some surgeons will allow tennis, and water skiing is sort of an iffy one. Some people let their patients do that. I do. Some people worry that with a knee replacement, the ligaments are at risk for doing that. Almost no one, and I dare say no orthopedic surgeon, will let you jog on a knee. And there's a difference between running around the backyard with your kids or grandkids or your dog throwing around a frisbee. That's fine. But to think you're going to do a triathlon or get back to jogging after knee replacement is not realistic. It's dangerous to the implant. I mean, I do have people who try to do it, but if you're a 150-pound male or female, every time you run and your heel strikes the pavement, you have to multiply your body weight by 4 to calculate how much weight goes through that knee. So for a 150-pound person, 600 pounds of force goes through every heel strike. And, you know, that implant is cemented to the bone. That cement is strong, but it's not unbreakable. And that polyethylene that I showed you the picture of is strong, but it's not unbreakable. And so I really tell people, have some common sense here. I know you could do it. You're a super athlete. I know you're a super athlete. But don't do it, because you're going to be here seeing me again, and we're going to be doing this all again in a couple of years. I'm going to go a little faster because, as usual, I'm talking too much. But so new implants. This is like orthopedics is so technology-oriented. It's inevitable that people ask this. How about the 30-year knee? How about a custom knee? How about the special superoxide knee? And I tell people, first of all, caveat emptor, buyer beware, okay? There are people trying to sell you things, and they will tell you what you want to hear. And those advertisements are not always backed up by fact. So be careful when you hear about a knee that's just come out last year, and the company's telling you it's going to last 30 years. How do they know that? And then, and my predecessor, who many of you may know, Michael Mayer, used to be very fond of saying, be neither the first nor the last to try a new implant. And I think that's absolutely true. Same as maybe you wouldn't buy a car the first year it comes out. A couple of other people try it out. Make sure it's not one of those metal on metal implants that's going to turn out to be the worst thing in the world since, for a long time. This is one of my favorite ads. This is an ad for a hip resurfacing implant for men. I'm absolutely serious. I mean, they picked their target audience just right. But that advertisement is for this implant. And, so the companies that sell these things are going after your emotions, they're going after ideas, they're going after aspirational things that you want to do. This is the striker get-around knee, triathlon knee. And I use this knee for a long time. I think it's a good knee. And it's got a clever advertising campaign. But there's absolutely no proof. So just to give you a quick idea of this knee replacement is shaped like a circle. So it keeps the ligament tension equal through the whole range of motion. Sounds like a good idea. Maybe it is. It's sort of a counter argument to the old knee designs that had a smaller radius of curvature on the femur so that you could get more and more and more flexion. There are no studies that have compared the two that have been well done. And even though there are claims out there that this knee is going to be better and you're going to be able to be more active, be careful. There's no evidence out there. Nobody studied it yet. I hope somebody does, but thus far nobody has. A few years ago there was an ad, two people walking up and down these incredibly steep streets of San Francisco, and they had a rotating platform knee and darn it all. And it was look at these people. They're happy. They're enjoying life. This is a good knee, but it is no better than some of the other knee implants that look very similar to this. And so again, get beneath the ad. If you see something that seems too good to be true, talk to your surgeon and try to find out if the appliance that's being advertised really does what it says it's going to do. Again, I talked about the 30-year knee. So 30-year knee, how did they come up with that? Well, they developed a new piece of polyethylene, not plastic again. And it may very well be a very good piece of polyethylene that's been out for 2 years exactly. They stuck it in a pressure cooker, essentially. An environment of high heat and high pressure to simulate 30 years of wear. And while it was in that pressure cooker, they cycled it back and forth to replicate the amount of knee cycles that a person in a 30-year time period would do. Turns out that's 45 million cycles, a lot of cycles. And then they came out and said, well, you know what, because that knee did so well in the pressure cooker, it's going to last 30 years. Now, once you start reading through this, they'll tell you, well, we can't really predict if it's going to last 30 years. It might. In the pressure cooker, it certainly seemed like it was going to. And so, if you really want to know the performance of your implant, the only place in the world that really does this well are the arthroplasty registries. And the US doesn't have one, just started one. I shouldn't say it doesn't have one, it now does have one, the American Joint Replacement Registry. But countries who have a nationalized health system have websites and have annual reports that publish the performance of every single device that's been put in that country. And the reason they do it is they identify the ones that stink and they take them off the marketplace so that they're not spending money on implants that don't work. And so if you look at those annual reports, and this is a big long statistical table, but there are 30 knee replacement implants there. And the important number here is the relative risk. If the number is smaller than 1, it's a better implant because you've got a smaller risk of revision. If the number is bigger than 1, like this 1.48, then your risk of revision is essentially 48% more than the average knee. 82 would be an 18% better performance than the average knee. So this is where the information comes from. It's going to be absolutely invaluable when the United States has its registry up and running because we use more of these than any other country in the world. And the amount of information that patients are going to contribute to this effort simply by sharing their experience with their implant I think is going to be a huge step forward. The other thing I hear is that people think that once you have a knee replacement, all pain goes away. Not everybody thinks that, but some people think that. And is that true? Well, it's true for a lot of people. A lot of people do have all or most of their knee pain go away, but not everybody, and that's important to know. And so, based on a lot of studies in the 1990s and the 2000s, about 85 to 95% of people got complete relief. The problem with these studies is that they were asking the surgeons. And so, all my patients get, of course they do. And it wasn't until more recent studies started actually asking patients about their knee experience. And these numbers all of a sudden look like they're not quite as good as they were 10 or 15 years ago. Now we see that maybe 15 to 25% of people still have some knee pain after knee replacement. I don't think we've got an answer for this yet. There are certain conditions, certain people, for example, get arthropfibrosis, and you probably have friends who had a knee replacement, everything seemed to be going great, but they never got their range of motion back. They never got to bend the knee, they were never able to fully straighten the knee, and nobody fully understands why that happens. And I think it's underreported, and I think it happens a lot more than we know. And unfortunately, right now, there's no way of identifying people preoperatively to say, okay, you're gonna get it, you're not, you're gonna get it. We're working on a research study right now at Dartmouth where when we do a knee replacement, we're taking a synovium sample, tissue that normally goes into the garbage can, and an extra blood sample. And we're actually, myself and Dr. Rigby, who's the chief of the rheumatology, are trying to see if we can identify from a blood marker or from a synovial marker the people that will end up with this condition. And the Norwegian registry on a much bigger scale is doing something very similar by sending people a little tube in an envelope. They swab the inside of their mouth, they provide their genetic sample, and then the Norwegian registry follows up with them, sees which ones are doing well, see which ones aren't, and hopefully we can eventually predict this before the surgery. Because I think some people probably wouldn't have the operation if they knew they would end up with a knee that's stiff and sore and painful. So final words. That's a quote from Francis Bacon: "Knowledge is power." Arm yourself with knowledge before you do this. Try all the non-operative options. Has to participate in something called shared decision making. This is a newer concept. Some of you may have heard of this, some of you haven't. Shared decision making means that your doctor doesn't just give you a brochure about knee replacement. Your doctor gives you a brochure or a booklet or a video that talks about surgical as well as non-operative options, because one answer is not the right thing for everybody. Make decisions while keeping your own unique perspective in mind. If you're quite happy to put up with some knee pain at the end of the day and it's not interfering with the types of things you want to do, then there's probably no need to have a knee replacement. But that answer is going to be different for each and every one of you, depending on what you like to do, depending on your health. There are risks to knee replacement: infection, blood clots, potential heart attack, and lung problems. And you have to know if this is the right operation for you. And that's something that your surgeon and your facility should help you with. Talk to people who've had these. You're going to hear some people who are happy as clams and other people who are not happy. But talk to both, because both are out there and either one of those outcomes can happen. Know the risks, know realistic outcomes, have realistic expectations, and talk to other people and find out if their expectations were met when they had their knees replaced. And finally, when choosing a surgeon, choose a high-volume surgeon. It doesn't have to be a university surgeon. Dr. Hood does a beautiful knee, and he's just down the road at a non-university center. But choose somebody who's done a lot of them and does them for a long time, because the rates of complication are lower in those centers, and the outcomes are generally better. Great, thank you. Went a little over time. Any questions? Yes?
How long does the average knee replacement last?
Great question. So the question was, how long does a knee replacement last? The simple answer is that it's measured by 10-year increments, and a 10-year survivorship of a knee replacement is probably about 90, maybe 95%. So if I do 100 of them right now and follow those patients in 10 years, 90 or 95 will still be functioning well, 5 or 10 will have been redone for one reason or another. That number has improved a little bit over the years. It hasn't improved a tremendous amount, a little bit. And it also doesn't differ very much between implant models. So implant company A, everybody's best implant is just about at the same level. Everybody's got a bad implant in their lineup that does miserably. Nobody's got some holy grail of an implant that lasts in 100% of patients after 10 years. Yes?
I forget what I had a knee replacement. I think you were one of the surgeons who did it.
Hope it's doing well.
What are the limits for what you should be able to lift and carry afterwards? I also have a hip replacement.
Yeah, probably the most important limits are in the first 3 months after the surgery.
Okay, so it's
because
not
at
so
that
much
point,
now?
yeah, so once you're out of that 3-month zone, common sense, but you can probably do just about anything in terms of weight. Depends on what your balance is like, depends on if you're walking on bumpy ground up and down the stairs. The first 3 months after surgery, you probably shouldn't lift more than 20 or 25 pounds, which is a shopping bag in each hand.
Yeah.
Yeah.
When someone is a candidate for a knee replacement, what kind of evaluation is done, if any, to assess how that new joint is going to function with hips, back, the rest of your skeleton?
Yeah, it's a great question. So orthopedic surgeons that do hip and knee sort of think in terms of hip, knee, back, exactly as you said, because that's sort of the axial, the core skeleton, and then the top part, in our view, the most important part of the lower extremities. And so you have to make sure that the knee pain is actually coming from the knee. That's extremely important. There are people who have spine problems and have a nerve irritation that is manifest as knee pain, but it's not knee arthritis. So it's very important to examine the back, get the patient to bend, straighten, palpate the back. It's important to move the hip around and make sure that the hip movement doesn't actually cause knee pain, because then the whole knee pain could be coming from the hip. We look at x-rays to look at alignment, and as I said at the beginning of the talk, some people are bow-legged, some are knock-kneed, and we really try to reproduce that alignment so that when you draw a line from the middle of your hip joint, which is right about here, down to the middle of your ankle joint, it should pass just about through the middle of the knee. So that's sort of a quick answer, but yes, all those things are important. We look at them, the questions get complicated when you get to somebody who has an arthritic hip and an arthritic knee, and we can talk about that after, but there are sort of views of which should be done first and which should be done second. Yeah.
Wouldn't you say that exercise is probably the most important thing one can do after they've had knee replacement?
Before and after.
before.
There's
and
actually
after.
studies that
Okay.
show physical therapy and exercises before you have an operation. Again, if you do this concept of two groups of people, one group of people did exercises before their operation, the other didn't, those people who did exercises before will do better. Less pain, better range of motion, more strength. But you're absolutely right. After knee replacement, you have to keep on doing the exercises. I often see people come back at 2 years and they're aching and moaning and groaning and their knee just doesn't feel good. And I ask them, what are you doing with this knee? And it turns out they're really not doing anything with the knee. So those exercises that your therapist spends a lot of time with you after the surgery need to be carried on afterwards to keep your knee functioning well.
And for a long time after too.
Yes.
For a patient who has significant atrophy in their leg prior to, is it reasonable to think that you will regain muscle mass at some reasonable level afterwards?
Yes, you will regain muscle mass, although if you really lose a lot of muscle mass because of an arthritic hip or a knee, I've seen many patients that will make huge gains but will never match the other side. And it's the same in the hip. There's studies done now that use MRI to look at the thickness of some of the muscles in the cross sections, you know, the nice pictures that you get from an MRI. And even 3 years after surgery, those muscles that became weak with arthritis still haven't gotten back to the same size as the muscle on the opposite side.
But does that mean you shouldn't wait to learn?
Yeah, well, so that's a great question. So the tantalizing risk of that question is that orthopedic surgeons like me are going to just start whisking people off the street and doing their knee replacement. But people are looking at that to determine whether people who wait too long, so to speak, have a tougher time of recovering. What I tell my patients is don't get to the point where you can't leave your house because you can't get down your own stairs. If you're that bad, come in and let's talk about options. On the other hand, I don't think at the first x-ray that shows knee arthritis and without trying all the non-operative things, you shouldn't rush towards the knee replacement. I'm going to hand these out. I'm sorry I've gone over time, and I'm happy to answer questions at the end. I'm going to hand out a couple of knee replacements. This is an implant that has a rotating platform. That's the one I said had the people hiking in San Francisco. Where's my bag? I also brought a partial knee replacement, which we didn't talk about. Not very many people are candidates for this implant. This is a half a knee replacement. And the problem with this is that most people don't get knee arthritis in half of their knee. They get it in their whole knee. And so this is good, for example, for somebody who's sustained a traumatic injury to one side of the knee and only has arthritis on one side. But that ends up being a minority of people. And then the final one I'm going to show you, and this is just proof that newer isn't necessarily better. This is a knee implant that's been around since the 1990s, and there's not a single implant out there that beats the long-term performance of this implant. So as much as we invent new things, sometimes the old things were just well designed and will work beautifully. So thanks again.
Which one do you currently use?
So, yeah, so in this day and era, a lot of hospitals are trying to save money and to lower costs, and so they make a contract with a single vendor. In our case, we've made a contract with DePuy Orthopedics. They have several knee implant models that we use. We do try to tailor them to patient activity level. Their implants on that chart from the Swedish registry that I show you do very, very well, and so that's what we use currently. Are they this heavy? They are heavy. They weigh about 1.5 pounds probably. Yeah. All right. Sorry, last question, then I'll let John have the stage here.
Titanium being used? Titanium?
Yes, titanium is the bottom piece of that knee replacement.
Not all?
No, there are some platforms that use a cobalt chrome piece instead of titanium.
Why is that?
Because you can polish cobalt chrome, and having a polished backing on that plastic, the thinking is it won't wear away the material as quickly. Thanks
Thank you
again.
so much.
All right.